Hello everyone. Today, we are diving into a fascinating and critical area of physical therapy, the world of cerebellar and vestibular disorders. Think of the brain as the ultimate command center for your body. Two key players manage your balance, coordination, and spatial awareness. The first is the cerebellum, a sophisticated processor at the back of the brain. It fine-tunes our movements to make them smooth and precise. The reason you can walk without thinking about every step, or reach for a cup of coffee without overshooting. It is the maestro of your muscles, ensuring harmony and perfect timing. The second player is the vestibular system, located in your inner ear. This intricate network is your body's personal GPS. It tells your brain if you are tilting, turning, or moving forward, and drives the vestibulo-ocular reflex to keep your vision stable as you move. As physical therapists, we are movement experts. Our primary goal is to help people move better and live fuller lives. Understanding cerebellar and vestibular disorders is fundamental to our practice. These conditions disrupt confidence and safety in movement. Patients often present with dizziness, falls, and a general feeling of unsteadiness. Without solid understanding, we risk mislabeling symptoms as weakness or deconditioning, leading to ineffective or even harmful plans. We are the front line of defense. The impact is immense. We can mitigate it. Fear of falling leads to inactivity, then muscle weakness, joint stiffness, and declining cardiovascular health. It is a vicious cycle. Trained PTs identify causes, recalibrate systems, and restore confident movement. We do not just treat dizziness, we restore freedom and quality of life. The first step is recognizing the signs. Symptoms can be subtle or dramatic, but distinguishable. For cerebellar issues, hallmark signs include ataxia with a wide-based, staggering gait, difficulty with rapid alternating movements, dysdiadochokinesia, dysmetria, consistently overshooting or undershooting targets. Intention tremor worsens as the hand approaches the target. Dysarthria, slurred, slow, or scanning speech. Abnormal eye movements, nystagmus or jerky pursuit. With vestibular disorders, dig deeper. What does dizzy mean precisely? Is it vertigo, spinning of the room or themselves? Lightheaded, floating, woozy? Positional vertigo with head movements suggests BPPV. Episodes are intense but brief. Many report disequilibrium, worse in the dark or on uneven ground. Vision reliance increases. Gaze instability. Do objects bounce when moving? A deficient vestibulo-ocular reflex points toward peripheral vestibular hypofunction. Once you suspect an issue, a systematic evaluation is key. Think like a clinical detective. The subjective history is your most powerful tool. Ask, when did it start? What does it feel like? How long do episodes last? What provokes or eases it? Clarify functional limits. Avoided activities? Any falls? Screen neurological and musculoskeletal systems to rule in or out contributors. Check cervical range of motion and pain. Assess sensation. Assess strength. Key myotomes. Check reflexes. Examine cranial nerves, with special focus on 3 IV and 6 for eye movements. Do not miss non-vestibular causes, like orthostatic hypotension or peripheral neuropathy. Oculomotor exam. Look for spontaneous nystagmus straight ahead, then to the left, right, up, and down. Test smooth pursuit horizontally and vertically. Assess saccades between two targets, your nose and your finger. Test the VOR with the head impulse test. Check gaze stability with head movement using a visual acuity chart. Let's break down key tests and what they mean. Dix-Hallpike is the gold standard for posterior canal BPPV. Turn the head 45 degrees, then quickly lie them back with neck extension. A positive test includes vertigo with torsional, upbeating nystagmus that fades within a minute. It indicates loose otoconia in the posterior semicircular canal on the tested side. Head impulse tests the VOR. In health, eyes stay locked. A corrective saccade signals hypofunction on that side, often seen after vestibular neuritis. For cerebellum, finger to nose reveals dysmetria and intention tremor. Rapid alternating movements show dysdiadochokinesia. Slow, irregular, clumsy. Timed up and go. Over 13.5 seconds indicates high fall risk in community-dwelling older adults. DGI and FGA challenge head turns, obstacles, and narrow base walking. Low scores confirm balance deficits. Results guide targeted, task-specific treatment planning. Once you have a diagnosis, formulate a tailored plan. Rehab is grounded in neuroplasticity, the brain's ability to rewire. For BPPV, Canalith repositioning like the Epley can resolve vertigo in 1 or 2 sessions. Vestibular hypofunction. Adaptation retrains the VOR through gaze stability exercises. Start slow, then increase speed and complexity. Use substitution. Lean on visual and somatosensory inputs when vestibular signals are limited. Practice on varied surfaces, with eyes closed, and in visually complex spaces. Cerebellar Rehab emphasizes compensation and strategy training. Reduce degrees of freedom, segment movements. Light weights and weighted aids can dampen tremor and enhance feedback. Progressive graded exposure lets the brain recalibrate, decrease dizziness, improve gaze and postural stability, and reduce fall risk. The journey can be long and challenging. Your encouragement matters. Educate clearly. Crystals can be moved, weak signals can be strengthened with specific exercises. Knowledge empowers active participation. Celebrate milestones to build momentum and confidence. Provide a safe place to push limits. Each recovery retrains body and mind. We witness profound transformations, fearful to confident, unstable to steady. From rolling in bed without spin to playing with grandchildren, these changes are life-giving. Never underestimate your impact.